Top Bed Talk.
This session is dedicated to Siobhan Mythen, who everybody will realise is Monty's sister, Katie's mum, Joan and Nick's daughter, and a friend to all of us. As much as the conference was founded by Monty and Mike, Siobhan was also a founder of the conference and was the backbone of it for all the time that I was involved, not right from the very beginning, but almost from the very beginning. She was an absolutely central element of the Centre for Anaesthesia in the Middlesex Hospital when Monty founded it. She is probably the definition of naughty in the nicest possible way. She was clever, insightful, emotionally and conventionally intelligent, and we miss her all dearly. So it's wonderful that we now have, as a tribute to Siobhan, this lecture that will be held every year in Dingle, hopefully next year really in Dingle. The Siobhan Mythen visiting lecturer. And we thought, Monty, Mike and I, this would be a good treat to her because Siobhan showed such enormous hospitality to the guests of Dingle and all the conferences that EBPOM organises, that it would be nice for us to try and continue in that tradition in her absence. So it's a great pleasure to introduce Jonathan Wilson. Jonathan is an old friend of Siobhan's and all of ours. He was a consultant anaesthetist at York Teaching Hospitals for 25 years and had escaped at the beginning of this year into retirement. He is a clinical academic. He will talk, I'm sure, about his research interest as part of his talk, which we're about to hear. I recently, about 2 or 3 years ago, I can't remember now, giving a talk about a national quality improvement programme, kept getting messages on Twitter and on the Slido feed from someone called El Capitano, and I didn't know who it was. They were asking slightly pokey but very important questions, and I thought, I'm going to have to work out who this is. And when I did work out it was Jonathan, the one thing that was clear was that he had to join our national team. And so he, in the last few years before he retired, was an enormous support to me personally as our national sort of clinical lead for anaesthetics for the National Perioperative Quality Improvement Programme in the UK. So in retirement, despite the lockdown, and since the lockdown, I should say, well, in the lockdown, we've just heard that he was decorating his house. But since then, he's been recovering his functional capacity by bagging Monroes. And I hope he'll maybe mention that a little bit in this talk as well. So, Jonathan, it's a great delight to have you here virtually. Thank you very much for delivering this inaugural Siobhan Mythen lecture. Thank you.
Okay, thank you very much for that introduction, Romani. It's indeed a superb honour and quite unforeseen to be the first Siobhan Mythen visiting lecturer, and it's quite pertinent, a bit of serendipity, that this is the virtual Dingle meeting, because it was at Dingle that I first met Siobhan in 1999, when we were invited to present our pre-optimisation work, along with a session with Hugh Montgomery and TJ Gann, no less. I was very much the third support act on that one, I can tell you. And we met Siobhan, who was just an awful lot of fun for us. And over the years, Siobhan was the only one who was ever allowed to call me by my first initial, which is Richard. I've always been called Jonathan. And so naturally, she called me Dick for the next 20 years that she knew me. And she is, as Romani said, dearly, dearly missed and rather naughty. Anyway, what we're going to do really is a little bit of a timeline through the whole sort of concept of flow-based hemodynamic optimization, and a contribution that the York team, my colleagues and sometimes myself, have put into this over the years. So it's a little bit of a sort of almost maybe an inaugural perioperative medicine history lecture, I suppose, to some extent. But I guess it's one of the sort of topics that's underpinned EBPOM from the very beginning. And so I can hope to do it some justice. There are some cautions. I have no things to declare other in terms of disclosures, but there are explicit references to PA catheters, albumin, dopexamine, and CPX testing, which some of our ivory tower colleagues may find a little bit depressing, but there you go. It starts 1978. I went to medical school at St Andrews, 3 years there and 3 years in Manchester. That was very interesting times. You got up to some ridiculous things like walking along the pier with severe hangovers on a Sunday morning, if you've been to church, and I think I did it probably once. But at the same time, over in the States, some much more interesting stuff was going on. And I think the founding sort of cornerstone was down to this guy here, Professor William Shoemaker, a surgeon and an intensive care doctor, one of the founding members of the American Critical Care Society. And he'd been fiddling around with pulmonary artery catheters in his high-risk surgical patients in South Los Angeles, and identified that those patients that were surviving tended to have higher cardiac indexes, higher oxygen deliveries than the non-survivors. This led him to pursue further work in this area and to conduct a trial that was published in Chest in 1988, coincidentally the year that after I fiddled around in the army for a couple of years, that I actually started anaesthetic training again in the army. And this paper, published in Chest, was a study of 3 groups of patients, 2 control groups, one with CVP management, one with a pulmonary artery catheter, and an intervention group with a pulmonary artery protocol regime, which basically it was aimed at optimizing oxygen delivery, optimizing cardiac index, and seeing if you could match the patient's parameters to those of known survivors, whether you could improve outcome. And indeed, you actually could. And he showed that the mortality rate, as you see on the bottom right, was much reduced, as were the complication rates per patient. So you'd think actually that if any other intervention in most other branches of medicine would become headline news, but this really wasn't. And I certainly, as a young anaesthetist, was not aware of this work at all. Maybe the link with pulmonary artery catheters was made it seem that it was very much an intensive care thing and not a surgical thing, not an anaesthetic thing per se. I don't know, but this was very early days. So what happened next? Well, we have to sort of cross back across the Atlantic, really. Good old London town. Things weren't so rosy there for the surgical patients. And here we owe a great debt to our dear departed friend David Bennett, Professor of Intensive Care Medicine and consultant physician at St George's Hospital in London. He realised the potential of what Shoemaker had been doing. And he also had been asked by Fisons, I believe, at the time, to have a look into this novel drug called dopexamine, which was a new sort of inotrope, a kinder sort of gentler inotrope, really, with beta-2 activity and some dopaminergic activity. And he recruited a vital piece of equipment in the name of Owen Boyd, a registrar, to perform this trial with him, looking at high-risk patients at St George's Hospital undergoing major surgery. Again, a control group of best standard peri-op care and a PA protocol group with a PA catheter inserted often before surgery started, and fluids and dopexamine to target an oxygen delivery of 600 mils per minute per square meter, and probably not surprisingly to most of us, came up with very similar results to Shoemaker's work in Los Angeles, almost 7 or 8 years previously, and with a much reduced mortality and morbidity. And again, you think really any other specialty, this would be certainly a widespread adopted technique. But again, I think the PA catheter side of it was probably putting an awful lot of people off. I think most people felt that PA catheters were really the province of cardiac anaesthetists and intensive care physicians only, and have no place in the vascular or general theatre. Just one of my theories. So, as it happens, luckily, other technologies were become available. And if we move across the River Thames into North London at a similar sort of time, a keen young thrusting researcher who bore a very striking resemblance, possibly a close relative of our co-chairman, was experimenting with the esophageal Doppler monitor. And again, David Bennett had a hand in developing this. And Monty did a trial on cardiac surgery patients as a young research reg, fairly fit patients, a good ejection fraction. A control group against a control group is the standard practice, but he was using stroke volume as measured by the Doppler to optimize that's your end target parameter with boluses of starch, and showed that there was a big reduction in major complications and length of stay in hospital in the optimized group. But I think of particular interest in this paper was they were using gastric tonometry, and they showed that those patients who were optimized had far less incidence of gut mucosal hypoperfusion, drastically reduced. So we were beginning to build up a little bit of a sort of theory as to why these techniques were working, that if you get in early with volume optimization and increased perfusion as required, then you almost splint open the GI tract circulation, you reduce gut permeability, and you reduce translocation of endotoxin and all the other nasties that can drive some of these complications. So that was what was going on sort of mid-90s, all very interesting. In 1995, the year of this publication, I actually became a consultant at York Hospital, and I'd done most of my training in either the Army or in Yorkshire region, so very provincial. And we were starting to get interested in this work, myself and my colleague Ian Woods. And it's quite pertinent because things were fairly grim up north. York itself is actually not too bad a place at all. It's a bit of an oasis of reasonable quality, I suppose, of socioeconomic status compared to a lot of the north, but it's still fairly post-industrial in those days. There were some interesting statistics coming out of district health authorities showing that basically elective surgery in the north of England was 3 times as harmful compared to the same population in the south, in the leafy, soft south of Hampshire, for instance. So things were a little bit grim up north, and I was indebted, and always have been, to this man here, Ian Woods, who was my colleague when I was appointed, who looked down the back of a sofa and found about 30 grand's worth of money from some obscure fund, which got us to employ research nurses for 18 months and allowed us to do a very similar trial to Owen Boyd's, really, in some ways, except with a couple of nuances. We looked at 3 groups of 46 patients, each undergoing major elective surgery, things like aneurysms, esophagectomies, high-risk colorectal procedures, that sort of thing. We had a control group of standard practice, do what you like, and anaesthetic and surgical teams. And most of those patients went to ICU post-operatively as a routine. And then we had 2 PA protocol groups who admitted beforehand to HDU. We optimized their fluid status, targeting their pulmonary artery occlusion pressure with albumin, which was free at the time, but may have had some additional beneficial roles, who knows. And then we used a low-dose inotrope, either dopexamine or adrenaline, to achieve oxygen delivery of 600. And this was then presented in a blinded syringe. So we just had a sort of a chart which showed us how much to increase it by to achieve the desired effect. And we didn't know who was getting what. In essence, most patients just needed the very low dose of either of these things. In terms of outcomes, we showed that whatever technique you use, whatever inotrope you used, you reduce mortality significantly compared to standard care. We were criticised at the time that this was our control group mortality of 16% was high, but the data was at that time beginning to filter through from ICNARC, the intensive care people, that actually elective surgical patients coming to ICU at the time in the mid-90s, this was a fairly valid figure. So does it matter what inotrope you use? Well, we were coming at this thinking that dopexamine was just a bit of a waste of money and adrenaline would do, but in fact, when you looked at the complications rates, things were quite different. Dopexamine had a big advantage in reduced complications compared to the control group and the adrenaline group. So they reduce the complications, not necessarily those are the ones that are going to kill you, but those are the ones that are going to keep you in hospital a long, long time. And afterwards, we did a cost effectiveness analysis with the health economics unit of York University, a respectable outfit. And they did this very fancy sort of Monte Carlo randomization technique with all the data I'd gathered on what we'd done to patients. And there's something like 9,000 iterations of the data in this bottom graph. But basically, if you're in the bottom right-hand quadrant, it means that you've got better survival and you cost less. So it's the sort of nirvana for all our health economists. And from that, they gained that there was a 98% probability that this intervention reduced costs as well as saving lives. So why isn't it getting adopted? Well, one of the problems was dopexamine was never actually licensed for use in surgical patients, merely for heart failure patients. But at the same time, a large drug trial that was driven by the company had been taking place in Europe. And it's useful to look at this because this is your sort of level 1 multi-center RCT across 13 centers. Very similar sort of setup, PA catheters, pre-op stabilization with fluids, then infusions, either a placebo, low-dose dopexamine, but then ridiculously, to most people's feelings, a very high dose of dopexamine. This was against the advice of David Bennett from St George's and anyone else who knew anything about dopexamine and tachycardia. And I'd also draw attention to the fact that there were mean ages in this group was something like 10 years less than ours. And there's a reason for this, really, and that was because of the recruitment in there, I think. If you look overall, there was a poor outcome with dopexamine in a high dose, but not much difference in overall survival between low-dose dopexamine and control. But if you dig into the data a bit more, and the old mantra that if you torture the data long enough, it will speak. You can see here that in this the group here who had the low-dose dopexamine, in patients who had more than one high-risk criteria or risk factors, just rather than having extensive cancer surgery, which was enough to get you in the trial, there was an overall feeling that low-dose dopexamine was creating a mortality advantage in these patients. But again, post-hoc subgroup analyses were deemed not to be acceptable for getting this stuff approved. So where did that leave us? Well, it left us in 1999, the year of our publication of our pre-optimization paper. We also came across this work from Paul Older in Chest, which was published the same year. Paul Older was a British anaesthetist who was working in Australia for some time, and he'd been looking at who exactly is the high-risk patient here. And he'd done work with cardiopulmonary exercise testing, because you're never going to get away with a talk from me these days without mentioning CPET. And previous work from him and Bob Smith had identified that patients with low anaerobic thresholds, i.e. they start generating lactate a lot earlier on in the exercise than they should do, for whatever reason, whether it's medical illness or whether deconditioning, those patients with a low AT do worse after major surgery. So he was using this to triage patients. And I'll draw your attention particularly to the column on the right, which is a negative predictor. He identified a cohort that if you put them on a bike and they looked fit, you could safely send them to the ward after major surgery, after particularly colorectal surgery, with zero in terms of medical problems. Only the surgeon can kill these people, really. So this was all going on in the background, and we were lucky enough in the autumn of '99 to fly out, courtesy of Edwards, to give lectures on our pre-optimization work in Australia, but also to get an opportunity to see CPX testing in action and allow us to start setting up our own service back in York. So where did that leave us now? Well, since 1982, Prince had been extolling us to party like it was 1999, and eventually it was. So it was time to pause and work out where we were. There were nuggets of people around the country, ourselves and people at UCH and various others like Newcastle and Worthing, who'd done some work and basically felt that, it was fair to say that hemodynamic optimization improves outcome if you're using flow-based monitoring. But there were many more questions, as always, thrown up. First of all, what's the real role of inotropes here? Do we actually need them? Is it not just all about the fluid? And secondly, the great fluid debate. And of course, this is very dear to EPOM's heart, underpinning many, many interesting meetings in the early days, particularly. And the debate, there were various aspects to the debate, but I think the thing that interests a lot of us at the time was whether you need to do this with colloids or whether you need to do this with crystalloids or whatever. And secondly, thirdly, who really are the high-risk patients here? And I think that was been a little bit alluded to by the previous work from Paul Older that I referenced. So we decided to set about looking at some of these questions in a bit more detail in York. And first of all, we decided to look a bit more closely at depexamine, because I think we were kind of using it routinely in our major surgery patients, but we felt, should we really be doing that? So my dear friend and colleague Michael Stone, when he was a registrar with us 2 decades ago and several chins ago, he led on this study with me where we had 100 patients undergoing major surgery, all of whom had the esophageal Doppler, which we'd adopted by then, inserted to optimize stroke volume, and then either placebo or depexamine in double-blind fashion for 24 hours, low-dose depexamine, to see if there's any difference in outcome. There was no difference in clinical outcome in this particular study, but I think of note is to highlight what we found in terms of your basic parameters as measured by Doppler. The cardiac index improved by 33% from baseline in patients just under control, just by fluid optimizing them during surgery. So the cardiac index was significantly higher than at the beginning. And if we look at peak velocity is a surrogate measure of contractility. And we've shown here again that by optimizing with fluid alone, you improve the contractility, and lo and behold, exactly what the Frank-Starling curves tells us. You increase the stretch, you increase the contractility up to a point, obviously. So this is all we're doing, and basically it seemed to be enough in most patients, which was, I suppose, gave us some pause for thought. And we thought, well, actually, we weren't triaging patients based on risk at all for this particular study. So we did another one, and this is my good friend and colleague, Simon Davis, who you've probably seen earlier on in the meeting. And he, as a young reg, did a study with us where we actually triaged the patients out using cardiopulmonary exercise testing to exclude the fit patients, the ones who only the surgeon can harm. We felt really wouldn't, we just become white noise in this study. So we excluded those, and we looked at patients undergoing major colorectal surgery. We had a different approach to optimization. We use preload responsiveness by now based on arterial line monitoring, looking at stroke volume variation in theatre after stroke volume optimization before anesthesia. And it's really just basically, this is a straightforward technique looking at it. I always say basically puts a number on the good old arterial swing. that worked quite nicely and is now basically default monitoring at York. And we use starch without any crystalloid to optimize preload responsiveness in theatre. And then patients had a dopexamine or placebo infusion. So the results were non-significant again. So again, coming back to this basically, if you optimize patients in the right way with fluid, whatever you're doing, you get very little advantage to using dopexamine. A minor aspects like return to GI function, but nothing else of any note. So where were we with dopexamine? Well, just to put even more confusion onto it, we had this study from St George's group again, Rupert Pearce and David Bennett, who'd done a meta-regression analysis using patient data from previous studies, including 2 of our own, to show that if you use low-dose dopexamine in optimizing patients, as well as the fluid optimization, that you got a 50% reduction in mortality. And this underpinned what was going to be the big study to end all studies, the optimized study. And we were involved in this at the beginning in terms of helping draw a protocol. But I think our biggest contribution overall was that my 16-year-old son at the time designed the logo that has been used ever since in this trial. And that was about it, really, because we couldn't actually put any patients in ourselves because my colleague said, look, hang on a minute, you've been telling us to use the Doppler in every patient, and now you're telling us not to. So we kept a very keen interest on it, although we couldn't contribute patients because we didn't have any equipoise. This was a massive, heroic undertaking with over 700 patients on sites across the UK with these admission criteria and the composite of defined complications or death within 30 days. And the intervention was standard sort of IV fluid thing based on arterial line monitoring and dopexamine infusion, but only for 6 hours after surgery against the standard care control group. And they nearly got it. This is where the lines between clinical significance and statistical significance really sort of get very blurred. And you can see that there was a 7% reduction in mortality rate in the intervention group. Now, across, I think that's fairly significant clinically. And if you look at the long-term outcomes, you can ask yourself which graph do you want to be on. So the fluid debate. Well, we move on to that. With dopexamine basically went west, nobody makes it anymore, and it got withdrawn. So the data that it needed to embed it never really got out there. The fluid debate was raging all this time, wet or dry, thick or thin, what do you want with that? And we contributed in York with our own study. We are used in the city to having excessive fluid. As you can see from the river who's burst its banks on a regular basis. And Mark Bellamy in 2006 came up with this concept, basically wet, dry or something else, because we were getting conflicting reports here from studies saying that actually you need to restrict fluid and other studies saying you need to give more fluid. Where do we sit on this? Well, you sit at the bottom of this curve, because if you give too little fluid, you'll get more renal problems. If you give too much fluid, you're likely to get more cardiopulmonary problems. That was a very simplistic way of looking at it. But we thought, well, if you're going to be sitting at the bottom of this curve, maybe you have to be careful about how much fluid you're giving. So surely starches are the way to go because you're going to give less fluid. So we did a double-blind RCT. My good friend and colleague, Dr. Yates, did this for me with Simon Davis and a big team of research nurses. And we looked at 200 colorectal surgery patients, again, excluding the low-risk patients. We had double-blind bags of fluid, all in black bags, etc., etc., etc. Usual optimization strategy. In this case, we did have to use rescue boluses of gelatins if we'd exceeded the dose, which we hadn't used in 10 or 15 years in York, and a post-op protocol based on urine output. Interestingly, by the time you looked at the total fluid balance over 24 hours, there was a very small difference. It was only a ratio of 1 to 1.2 in colloid versus crystalloid. And when you looked at the overall clinical outcomes, there was no difference at all. In fact, if anything, you could possibly suggest there was an increase of hum if you see colloid rather than crystalloid. So what about the patient then, the high-risk patient? As I said, you're not going to get away from a talk with me these days without mentioning CPX testing, or CPET as we call it now. I think we all agree, hopefully we all agree, that functional capacity assessment in some shape or form is important for major patients undergoing major surgery in particular. Whether it's a questionnaire such as the Duke Activity Status Index, or a qualitative assessment, eyeballing a patient, getting them to walk up and down the stairs, or But we've always preferred a quantitative assessment, sticking on a bike and getting some numbers. Everybody likes numbers. We're anaesthetists after all. So since 2001, we've been doing cardiopulmonary exercise testing, initially in aneurysm patients, and then latterly patients undergoing a wider range of procedures, particularly colorectal and major urologic cancer procedures, measuring the standard parameters of oxygen uptake at VO2 peak and anaerobic threshold, but also ventilatory efficiency and myocardial ischemia, which you can diagnose on gas exchange. So we've done this over the years. By the time I'd retired, I think we had something like 6,000 patients on the database, and we had queried the database for various different outcomes and relating it to different parameters from CPX testing. And I think the last two papers that we put out are probably the way this is going to go in the future, where we're sort of left anaerobic threshold a little bit behind, and we're talking more now about the diagnosis of ventilatory inefficiency with CPAC testing, and also the diagnosis of exercise-induced myocardial dysfunction measured by the oxygen pulse. There is no time whatsoever to go into the nitty-gritty behind these. I hope you all sign up to go on a proper course, and Denny Levitt will be waiting with her pen and paper afterwards to take your names. We'll talk about this one very, very briefly. This was a study in just under 1,400 colorectal cancer patients, looking at 90-day mortality, which is the standard outcome parameter in this group. And we looked at all the factors, we put everything into the statistical grinder and to look for independence. And the only things we came up with were being a chap, being 80 or older, and then having inefficient ventilation with a minute ventilation to CO2 production greater than 39. What that means is you've got marked VQ mismatch, generally from usually from cardiac dysfunction, but also possibly from respiratory dysfunction. In this series, anaerobic threshold did not feature as a significant parameter. Now, nearly 20% of your patients will have this degree of ventilatory insufficiency if they're anything like our patients in York. 60% of those patients will have no known cardiorespiratory risk factors. So your questionnaires, your history taking are unlikely to pick them up. If you shove this into an overall scoring system, and to this one we added in also gas exchange evidence of myocardial ischemia, then you come up with three groups based on the number of risk factors you have. 0 and 1, low risk. That's just over half your population with a very low mortality. And again, it's usually only surgical complications that cause that mortality. Compared with the high risk group, 15%, mortality that's over 10 times higher. So aside from the fact that this is maybe, you're going to have different conversations with patients in different risk groups, it also makes me raise my eyebrows sometimes about what you see in the very big trials that have an incentive and a pressure to recruit large numbers. Are we over-recruiting too many low-risk patients that just produce noise in big trials? Just a thought. I'm going to change the subject very slightly, really, because all this stuff really brings them around to the more modern concept of perioperative medicine. Now, this most of you old enough, like me, to have seen the original Jaws in the cinema will remember Captain Quid, played by the great Robert Shaw, yakking on about how he was in the water in the South Pacific in the war. And this was the reason why. His character had been a sailor on the USS Indianapolis, which, having deposited the atomic bomb at the relevant island from which it was then taken, sadly, over Hiroshima, the USS Indianapolis then was basically set off on a bit of a jolly cruise around the South Pacific with no specific aim in mind. Nobody had actually remembered to tell it to ask it where it was going in the first instance, but or to tell it that there were still Japanese submarines operating in the area. So after a couple of days, late one night, it got torpedoed and sank very quickly, and 900 men went into the water. But they were there for something like 3, 4 or 5 days, I can't remember exactly, before anyone spotted them, because nobody knew where they were. There was no communication. The whole thing had been a bit of a shambles. And so there was, to coin the phrase, a complete to rescue. A bit corny maybe, but as an anecdote, it's very useful. And I'd recommend any of you reading the stories about this and the survivors and how they got through the PTSD. It's very interesting. Because it leads us on to this concept of failure to rescue in our perioperative patients. And this, I think, is one of the must-read papers for anyone who's got an interest in perioperative medicine, because it underpins the whole thing. This paper by Conferi in the New England Journal from 2009 looked at 200 American hospitals who contributed high-quality data to a high-quality database. a real mixture of hospitals, teaching, community, whatever. And they split them into 5 groups based on the hospital mortality for a basket of 5 major procedures, such as aneurysm repair, colorectal resection, that sort of thing. And they noted that the incidence of complications, including major complications, was the same across all these quintiles that were based on the overall mortality. But the mortality in the highest quintile, the highest 40 hospitals, was twice that of the mortality rate in the lowest or the best 40 hospitals. And there was no difference in these hospitals. There was an equal scattering of teaching hospitals across these groups. But they were led to conclude, they supported previous theory, that there was a failure to rescue patients when they were going off. And they said there was a failure to recognize complications, a failure to treat adequately. And I would add to that, in the first instance, a failure to identify that there was a risk in what was going on to that patient with that operation. So, closing notes really, the perioperative quality improvement program, I was honoured to be involved in this in the early days with Ramani for about 3 or 4 years. And I think I hope that this gets established in major practice and is funded adequately, that it becomes sort of, basically a bread and butter of perioperative outcome, because you can't do anything unless you know your outcomes. And it highlights really the ability of individual units to do good things and to share good things, elements of practice, not to rely totally on level 1 evidence, but to share other things that are going on, good single centre stuff. And we set up a perioperative medicine team about 5 years ago in York. I say we, that's the royal we. It was set up predominantly led by David Yates and now by Katie Ayash. And we aim now to do ward rounds, or I say we did, when I was working, we did ward rounds on the surgical wards afterwards. And certainly David has the evidence that he can talk about in other papers to suggest that we were doing good work. So the song remains the same, I think, was the original title of this talk. And why did I say that? I'm not a massive Led Zeppelin fan, like the usual tracks, but there you go. That was their famous album. And it's because of this paper here, largely, that I got sort of excited about this. It's come out in the BJA just very recently from a group in Austria, I believe. And I kind of like this because it's a good old-fashioned single-centre retro hemodynamic optimization trial. I say good old-fashioned because it showed good results. But basically, this group had a good series of high-risk patients undergoing abdominal surgery and were allocated to either routine management or personalised hemodynamic management with fluid, plus or minus dobutamine, to maintain a baseline cardiac index. So there's a modern nuance of actually looking at the patient's own baseline cardiac index and using that as the target, with a standard primary outcome of composite deaths or major complications. And the composite outcome was almost halved in the intervention group, the greatest hits being a reduction in mortality, acute kidney injury, and surgical site infections. And you'll note that, there was no difference in the fluids that both groups of patients got, none at all, but the intervention group got, about a third of them got dobutamine. So it comes back to this sort of slight conundrum. Yes, fluid underpins everything, but maybe some patients need a little bit of tickling as well to get them where you think they need to be. So, as alluded to by the lovely Ramani earlier on, yes, I do enjoy hauling my significant habitus up Scottish Munros when given the opportunity. Mrs. Wilson said, yes, this is your time now, you can retire, you've got all the time in the world. So I did, and we went straight into lockdown. I was lucky enough to get away to Scotland, though, at the beginning of September, and these are the reasons we do it. But there's really just a couple of things to mention in my concluding slide, really. I don't think you need to know sign bias, you just need to know a couple of figures. First of all, a sort of surrogate marker of your Frank Starling curve, load against stroke volume against preload. Get your patient, optimize the fluid, and ask yourself the question, is perfusion adequate? And it doesn't matter what you do, as long as you do it consistently and well, you know what you're doing with it. We have arterial lines in virtually all our major surgery patients, and we would use lactate, but various other parameters maybe to help you make that decision. And I guess the data would suggest that maybe 70% of your patients will be absolutely fine with fluid alone. But if you're not happy with that, then you might want to tickle them up a bit with some vasoactive medication. And the second figure to think about is this one here. And that's basically the wet, dry, or something else. The answer is at the bottom, isn't it? The answer is hit the patient's sweet spot with the fluid. But I would suggest that your lower risk patients with green in the green have probably more tolerance and a wider sweet spot than your higher risk patients in the red. So it's a good idea to know who those high risk patients are. Good. Well, that's me pretty much done now. I'd just like to take the opportunity to thank, first of all, the meeting organisers for, I feel honoured to have been here and to present this lecture. And thank you for indulging me just wittering on about what we've done in your
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.